should start from the concept that everybody knows exactly what is the state of the art till today. Let's start from this image that shows that there are different structural interventions that we can offer to our patients. We are very confused at the moment what would be the best treatment for each individual patient, what is the right timing for the intervention. And here is a kind of a representation of my thinking. This is what we published together with a few other authors as a state-of-the-art in transcatheter interventions. And I would say that there is no one single solution. It very much depends on the anatomy, morphology, the phenotype, but also about the time you are intervening. If you intervene earlier, there are solutions which are probably better than others. If you intervene too late, there are other solutions. Now, this is a very important point, but also is a great simplification for the reason that I mentioned before. Tricuspid regurg is not one entity. There are so many phenotypes, and each phenotype comes from a different history. It's a huge difference between a patient with previous left heart disease, who have been probably operated of mitral valve, from the patient who has a pacemaker, from the patient who has been transplanted, from the patient who has AFib. Each of these phenotypes today is treated the same way. We don't know how to differentiate our decisions. But there is one common ground that till today, we believe that the tricuspid patients are these ones, and this is not true. Most of the patients we see are not the typical Netter picture with ascites, leg swelling, end stage. This is an end stage disease. Do not try to treat these patients. It's going to be only palliation. You can try, but you will be very unhappy. Most of our patients who are symptomatic, despite therapy, they have no leg swelling, most of them. Few of them have ascites, but they may be tired, they may have problems with digestion, they have severe TR. These are the patients where you need to think about treating before they become this kind of inoperable patient. And why it is so important, because for my lecture about what to do, because I don't believe there is anything really I can tell you what is the best way to treat these patients. But there is only one thing which is clear to me, that we need to define a trigger for a structural interventions prior to organ damage. The mitral valve insufficiency is damaging only the pulmonary circulation. The tricuspid valve insufficiency is damaging everything else. It is an internal medicine disease. The patients become a metabolic patient because there is venous hypertension in all the splanchnic organs, including the gut, and the patient becomes irresponsive to therapy most of the times, not because of renal dysfunction, but because of they are not absorbing drugs. So that is the element of the choice, the timing of intervention. And by the way, let's start now the discussion about update on surgery and transcatheter interventions. Surgery is considered to be high risk for these patients, which is a fake news. Surgery is high risk in high risk patients. If you have a low risk patient, surgery is a perfect solution. This is data from San Raffaele Hospital collected in 20 years. Very few patients have been operated, to be honest, because usually they have been always referred too late. But if you see those patients who have been operated in stage 2 and 3, so before organ failure, mortality is 0. It's not the typical 8% mortality reported in most cases. So let's see a typical vignette of a patient, a 51-year-old man or a woman comes to the hospital with an occasional finding of tricuspid insufficiency. This is the image. You can see, first of all, 2 ventricles are moving. I'm not sophisticated. I don't have a spectral tracking here, so I don't know anything. But they move well. And I'm a surgeon. Sorry, brain, the cortex is very short. But there is a TR, and I see that there is something moving strange. So probably there is an excessive motion of one leaflet. It's a primary TR. Probably this patient had who knows, maybe an endocarditis, trauma. We don't know why she had this, but it's an isolated TR with some flail, and she's 51 with no many comorbidities. So we measure the tri-score. It's an app. You need to have it. And by tri-score, she has a tri-score of 0, so no risk profile. So the predicted in-hospital mortality for this patient would be 1%. This patient goes surgery. No discussion. It's an early indication, normal right and left ventricular function, no pulmonary hypertension. This is the kind of invasiveness we have. She's young enough. That's another point. If I have a score of 0, 1 in a 80 is a different story. She's 50. She has many years to go, and what she gets a Clover technique, so an Alfieri technique to fix this prolapse in addition to a ring. This is what you get at the end of the procedure, very minimal residual TR, and this is what you want to achieve, okay? Now I talk about the tri-score. Tri-score is a very important score which has been generated specifically for isolated tricuspid regurgitation. As for any score system, has a huge limitation. It's been based only on those patients who have been operated. But even in this subset of patients, so only those patients who have been operated, you realize that as the number of comorbidities, so the factors are on the left, as the number of the risk factors increases, the mortality increases exponentially. And as you reach the risk score of 3, 4, you need to start thinking about something else, in my opinion. And something else is, we have seen already this image about the choice, the algorithm for choosing different transcatheter devices. There are different options available. There is TEER, annuloplasty, replacement, a lot of replacement, a lot of TEERs will come, a lot of new annuloplasty, a lot of out-of-the-box devices, but 99% of patients are treated by TEER. Why? It is available, easy. It's not the easiest procedure, but it is the one we have. It's the one we have in Italy, for instance. It's the only one which is sustainable because replacement is not reimbursed. So we do this procedure, which is highly depending on a imager job. So it is made that from a technical standpoint, the main challenge of this procedure is to obtain a good image and to interpret that specific picture we have seen before together. Another vignette. So this is a 70 years old lady now with this with patient who has had a surgery in the past. Was mitral valvuloplasty. Sorry, it was not surgery. It was balloon valvuloplasty, I think. And AF ablation. She had the recurrence of atrial fibrillation, and progressively she developed tricuspid regurg. Symptoms: lack of appetite, sense of heaviness after lunch. This is the most of the symptoms. But now let's look at the heart. Now we have a heart which is very remodeled. The right atrium is very large. We'll come back to this one. I think we spend a lot of time assessing RV function, but RA function is also highly predictive of the outcome of these patients. You can see it's a very severe TR. There are some other things, but not so important. The annulus is very dilated. The leaflets are not tethered. This, we call it, I think, I don't know, Denise, it's a atrial FTR. Yeah, maybe atrial FTR. For sure, the ventricular function, again, we don't have the sophisticated analysis, but it's moving well. And this is the, if you think about the glide score here, it would be a quite high glide score. You see the jet location is through all the coaptation line. And so maybe this is the 3D picture that you were asking for. Not always 3D is great, so sometimes difficult. So let's have a look at this procedure. That's, is a long video, so I will cut it short. I will cut it short to some little pictures during the procedure. So as you can see, the procedure is guided basically by transgastric views. So the one that I told you, you need to become mesmerized, correct? You need to become like hypnotized by that image. You try really to enter into the image and imagine that what you are doing is just really, you need to touch the leaflet, to know where they are. And then you start acting on these leaflets. And as I told you, in these patients, I usually tend to implant two devices, two well-implanted devices. Interestingly enough, look at the devices. They are not at the same plane. Okay, why? Because the coaptation line is not regular. It's very irregular, and that's why you have one going one direction, one going in the other direction. Anyhow, this is the outcome of this procedure. Obviously, I will not come here to show you bad outcomes, but bad outcomes happen. One out of three patients have an outcome which is not sufficient for changing their prognosis. This is a good one. You can see at the end, maybe if you look at the left picture, you can count how many holes we have left. I can count at least 3, maybe 4. But we keep counting. I don't know, maybe we get to an agreement. How many? 4. Yeah, maybe. But there are only 2 clips. So how comes this? I don't know. I mean, whatever. This is just, when you don't know what to say, you create confusion. It's enough. And this is the transthoracic echo, which is always important because sometimes on transesophageal you can fake good outcomes, correct? If you cut the right position. Now, what is the beauty of Transcatheter and particularly about TIA is the safety. Let's talk about something positive about this procedure. It's very safe procedure. It can be attempted, and to be honest, it should be attempted in these patients. So safety is a key element because the patients with surgery, they don't die of the surgical act. They die of the inflammation related to the heart lung machine in a patient with a metabolic disorder. TIA, it can be done also in a patient who is highly stressed in terms of metabolism and inflammation. Triluminate showed in very selected patients efficacy in reducing TR using the TriClip technology. Also showed, interestingly, at 1 year after randomization that the control group under guideline-directed medical therapy had no improvement of TR, which is to some extent unexpected because in the COAP trial, the control group, after being enrolled in the trial, they've been improving their MR, which tell us that actually our drugs are not really efficient in tricuspid regurgitation. And what this trial found, they found nothing else than improvement in quality of life. Is it an important outcome? Nobody knows. There is a lot of debate, but at least this improvement has been linearly correlated with the reduction of TR obtained by the procedure. That tells you 2 things. One is that, yes, maybe there is a placebo effect, but it's a strange placebo effect because the patient doesn't really understand the grading of TR. Number 2, that if we want to improve the quality of life of our patients, we need to do a good job. The 1 year outcomes came out negative, no difference between control group and the other one. And the bad news is that after 1 year, there was the possibility for crossover. So basically, the 3 Luminate has been a trial which is not so useful, because now, after 1 year, this is the crossover. 1 year later, a lot of patients have been crossing over. You can see this is a freedom from mortality, surgery, and tricuspid intervention. So it means that if a patient got a TriClip after 1 year of randomization, is in the red line. Now, in this construct, which is somehow confusing, still we can see some little messages. First of all, you can see the 2 curves diverging, where the control group seems to have more rehospitalization, despite it's an intention to treat. And also here it's pretty interesting that it shows that those who went into crossover, so the red ones control going into crossover, were the ones that at 1 year had the worst quality of life, and they recovered quality of life after the procedure. So these are signals, again, somehow poisoned by the fact that these are open label trials. They're not sham controlled. So there might be some bias due to the placebo effect. What is not related to placebo effect is another study coming again from Triluminate that shows the change in regurgitant volume and the change in the RV dimensions after the procedure. And it is a line. It's amazing. The more you reduce the TR, the more you obtain RV reverse remodeling, which I believe is the target of this therapy. Which means, again, that you need to reach at least moderate, maybe even less than moderate TR to bring the patient back from the risk profile. Denisa is a strong believer that moderate TR is the threshold of prognosis rather than severe TR. Obviously, it's a linear relationship. The more TR, the more the prognosis, the worse the prognosis. But the threshold between being okay and being at risk is moderate. So if we treat these patients, we need to bring less than moderate. And this has been shown in several publications. This is another publication that shows that if you get more than moderate, no big change in natural history. And therefore, it enters the concept of replacement. So replacing the valve will fix the valve completely. And this has been achieved somehow with some drawbacks, a high rate of pacemakers. What is the future of this? We don't know. And obviously, the need for long-term anticoagulation is another problem. There are many other technologies with many limitations. Unfortunately, at the moment, there are no CE mark devices for annuloplasty, which I believe still should be the #1 solution for these patients. There are some palliative procedures like CAVI. I don't know if anyone have had patients who underwent CAVI, and there are some centers who are really believers in CAVI, and they have been able to show some degree of benefit, not in my career, but maybe somebody will debate on this. I think CAVI is a palliation for end-stage patients. And again, let me conclude with anything else. So whatever we do, again, it is the timing. The earlier, the better, because the outcome finally is highly depending on the comorbidities. So I took some of the latest publications for an example. Inflammation. The C-reacting protein in the blood predicts for the outcome after the procedures. Organ failure, kidney, obviously. Patients with renal failure, they have much worse survival. Another example, remodeling. RV, RA dimension, both in combination or even in isolation, even only the RA, maybe the RA better than the RV, they predict the outcome. The larger, the worse. And finally, if you treat patients in the earlier stages, whatever you do, this is a study showing outcomes after surgery or interventions using the TriScore to stratify patients. Those with a TriScore less or equal to 3, remember 3 was associated with 8% mortality in surgery. So we're not talking to really a very low risk patients, but reasonable risk patients, 3, you get good outcomes, anything you do. If you treat patients who are above, and if you go in TriScore more than 6, obviously we are doing palliation. These patients have no big difference between doing something or treating them medically. So, who, when, what to do remains a largely debated question. Imaging will be helping us a lot, but I want to show you the last slide, which is my slide, what I can bring to you, because I have a unique opportunity. I'm a surgeon doing also interventional procedures. In front of a patient, I'm always doubtful. I never know what is the best for this patient. So how do I choose myself? Number one, it's a clinical decision. We've been talking about this. Evidence will help us. Analysis of the risk-benefit profile of different options. Durability and lifetime management is also important. So all this is important. This is what we know. Then there is what we can do, the technical feasibility. Usually I like to choose the simpler one, the more predictable one, the one which is obviously less invasive, but obviously I also have to do the one which is feasible. And after this, I will still have doubts that I have to negotiate and discuss with the patient. So the first and the most important factor for the decision is the empathy, which is something that you can achieve more than me. You are at least half an hour with the probe in your hands and you talk to the patients. You need to get the patient point of view, and really you need to negotiate through a complete and unbiased information to the patients, which is very difficult. But I think, now it's important. I want to share this because
it's been cancelled, Michel.
Yeah. No. But it is a very important, it's an interventional imaging meeting here. And I want to say once more, in my life, I've been privileged to work with a lot of good people, but never as good as with that man on the right. And I tell you, for 3 reasons. Michel is an excellent cardiologist. I think there are many excellent cardiologists here. But there were 2 more things. One, during the procedure, he was bringing patients from his own GP practice. He has a GP practice. So he knows the patient history like nobody. Imagine you take a decision with the person who knows the patient best. So all the compromises that we need to achieve during a procedure, we debate and we decide, and I know I'm taking the right decision because I have a support. And then number 3 is the cheerleader. So he was so happy when things were going well. He was like, yes. Yeah, and we need support. So that's why I think you can be an incredible player in this field if you believe in it. And we need you as much as I can tell you. I cannot do without you. Thank you.
Francesco, thank you for that tour de force. Amazing and comprehensive presentation. I think we're going to take 5 minutes for questions, Alison, if that's okay. Any questions from the audience, firstly? Perhaps while the audience are warming up then. Francesco, I'm interested in what you said about the annuloplasty device. Do you think if in the next few years there is a commercially available annuloplasty device that is effective, that is easy and quick to use, that it will see the death knell, that it will stop us needing to use TEER? Will it replace it?
It's not stopping it in using TEER. I think annuloplasty would work very well on the posterior half of the valve. I think still the anteroseptal lesions are best treated by TEER. But we failed in the posterior half. And the reason is very simple. We have a very large anterior leaflet, which is almost always in every patient present. And in that half of the valve also, annuloplasty fails because we can't anchor on the aorta, while we can anchor on the septum on the other side where you have the coronary sinus. So we can be very efficient with partial annuloplasty. I think, if somebody wants to do an annuloplasty, the big mistake of Cardioband was to try to make a complete annuloplasty. There are solutions, there are technologies today which allow also to have a shorter annuloplasty, which means faster, maybe easier. I don't know. We need easier for sure. But annuloplasty, my prediction, will come back after, somebody, particularly in Switzerland, they stop debating about the Cardioband. Edwards hopefully will come with their new device. I hope they will understand also the beauty of being partial rather than complete.
So it's going to be complementary, part of the toolbox rather than replacing anything else.
Could be also standalone. In my practice as a surgeon, I am using less and less annuloplasty rings and more just a suture in the posterior annulus. So and it's working. So I think in my practice, if I had an annuloplasty, I would start with annuloplasty first. If there is residual TR at the level of the anteroseptal commissure, probably I would go for TR because it's more predictable.
Amazing. Yeah, I just wanted to say, I think it makes a lot of sense because we know that, for instance, these patients, 90% of them are having atrial fibrillation, and there are some pathophysiological studies showing that these patients tend to remodel the annulus posteriorly. This is one of the reasons why we are underestimating. If we measure the diameter septal to lateral, we underestimate the annulus. So if you are able to provide the TEER anteroseptally and then stabilize the annulus, because you are treating the valve, but you are not treating AF. AF still remodels the right atrium afterwards. So I think it makes a lot of sense what you're saying.
Yeah, and we need to treat AF if possible. Huh? That is another, we never speak enough about it.
Could I ask Michelle a question about the comment about the commissures for the audience who are, as Francesco said, predominantly imagers? Before that, you see the valve as a surgeon. Is it true that there are more than one papillary muscle in the right side?
I tell you a story. I tell you a story. It's quick story. Please. I have an Indian fellow that comes to me, very nice guy. I just met him a few days ago again. 1 year ago, this guy comes to me. He's a great guy with reconstructive CT images. And I had an idea. I said, listen, I think, leaflets, we try to see them on echo, but we are always fooled by these images. Why don't we do the opposite? If there is a commissure or if there is an indentation, by definition, you need some subvalvular apparatus below the indentation. So I would like you to do this job. Take a CT scan, find the three papillary muscles, the anterior, which is the big one, the Lancisi one, which is in the septum, and the posterior. Find me the three papillary muscles and project them in the three-dimensional space and tell me what is the line of coaptation. So I go TEER, I make my orientation based on the three papillary muscles. The guy comes back after a couple of weeks. Sir, we have a problem. What? I didn't find three. There are at least four. At least four. I don't have the picture with me. I have one of these CT scans where we found 7. So the reality is the following, in my opinion, and this is a discussion. Maybe Christina will hate me because I'm still convinced. We only have one large papillary muscle, the anterior one. Anterior can be more or less anterior. That is the point. Can be more or less anterior. The more anterior, the smaller the anterior leaflet. The more posterior, you're going to be larger the posterior leaflet. And then you have a number of other papillary muscles, which are, can be 2, 3, 4, because the posterior part of the annulus is very much segmented, and that's why probably also it enlarges more. because there are more clefts. The anterior leaf is holding the annulus.
Alison, perhaps we could finish with a question from Michelle. Did you want to finish with that?
So how do you identify these commissures or these indentations on echo?
In a tricuspid?
Yeah.
It's difficult.
I think that's
No, we can tell them it's very easy. It's not easy. Sometimes you cannot even say if they are there or not. If that is not what you expect from me, but that's the truth.
Yeah.
We can see what we heard. We can see on the commissure behind the aorta. So also the interventionist know exactly where we are. So we know where the anterior and the septal leaf is, where you are going to put the first clip. That we can say really clear. But then it's getting difficult to tell where to go next.
Well, I think it's a worry if you don't know.
Yeah.
If you don't know, and Francesco doesn't know, then none of us knows. Go on then, Francesco does know.
No, I don't know. I think, it's coffee time. For those who want to coffee, go for coffee. For those who want to understand the anatomy, stay here for the next
No one can now leave. Nobody can now